Good morning. It's my pleasure to introduce Janina Kittel. She is a fifth-year resident and she started in Oldenburg and did there 2 years. And now she's for 3 years with us. And today's topic is the abdominal wall, postpartum diastasis recti. Enjoy.
Thank you very much. Let's have a look at the content of today's talk. First, we're going to talk about anatomy, then etiology of the diastasis rectus abdominis, which I will refer to as DRA in the next 20 minutes. Then we're going to have a look at several classifications, talk about the clinical relevance of the DRA, as well as the treatment options we have and how and we do at our department. And then we draw a conclusion of today's talk. So let's have a look on anatomy. The linea alba, the white line in between the rectus muscles, stretches out from the xiphoid to the pubic symphysis. And it's not a straight line, as it differs in width, with the widest part around the umbilicus. And it's also not a flat line, because it's getting thicker from the top to the bottom, with the thickest part just above the pubic symphysis. So when it comes to measurement of the linea alba, it's very important to keep the positioning of the body in mind, as you can see here on this graph, because the distance of the linea alba is wider in standing position than in lying position. Here you see a cross-section of the subcutaneous fat tissue. Let's start here with the skin. Then there is the subcutaneous fat tissue, rectus muscle, linea alba in between. And I want to show you another cross-section, because it's very important to notice that sometimes there's a false positive diagnosis in imaging when it comes to diastasis recti. Because as you can see here again, skin, subcutaneous fat tissue, rectus muscles, and fatty deposit in between the rectus muscles. And this can be mimicking a rectus diastasis in imaging. When we talk about the build-up of the linea alba, it's made up of 3 laminae. The first laminae deriving from the oblique abdominal muscles is the laminae fibri obliquae. The second one in the middle is the laminae fibri transversae, deriving from the transversus abdominal muscles, and the last one is the fibri auricularum. And actually, those laminae are named according to the orientations of the fibril bundles. And it's very important to notice that, first of all, women tend to have a greater layer of transverse fibers. And secondary, women tend to have a smaller or thinner linea alba at the infraumbilical region. Anatomy also includes vascularization. So let's have a look at the vascularization of the linea alba and the rectus sheath. The vascularization is derived from the inferior and superior epigastric vessels, as well as the superficial epigastric vessels. Here you see a picture of that. So it's highly vascularized, and you can see that here all those blood vessels. So rectus sheath, linea alba, umbilicus. And it's very important to try to keep this vascularization intact when it comes to surgery, because otherwise you might find a necrosis of the linea alba and the rectus sheath, or if you cut too much of the lymphatic vessels, which are also placed here, you will have a high risk of a postoperative seroma. What is the pathophysiology of diastasis rectus abdominis? Well, actually, it's pretty simple to imagine. When it comes to raising abdominal pressure, the rectus muscles are pushed aside. And what happens next is they get longer. And if they get longer, they cannot contract to the full amount anymore. And if this happens, the patient will lose its muscle force. So the Journal of Orthopedic and Sports Physical Therapy published an article in 2011 in which the relationship of the interrectus distance as well as the abdominal muscle function in postpartum women was measured. And what they found out was that there's a gradual decrease in the distance after pregnancy, but the baseline values are not established at 6 months after pregnancy. So I want to ask you residents, what do you think? Which kind of women are at higher risk for developing a diastasis rectus abdominis?
I would say women who had multiple children because the muscles are worn out by having multiple pregnancies.
That's totally correct. Thank you very much. Multiparous women are at risk for DRA. But when it comes to abdominal laxity, you have to be sure, or you have to know, that the linea alba is limited in stretching up to 6 centimeters. So there must be concomitant factors. Well, actually, abdominal laxity also included the weakness of the anterior rectus sheath, as well as maybe the whole muscular abdominal wall. There are some other relevant additional factors like obesity or prior abdominal surgeries, but actually you can conclude that diastasis rectus abdominis can be a combination of myofascial laxity and widening of the rectus diastasis. Let's come to diagnosis. Actually, the diagnosis of DRA is a clinical one. So if you ask the patient to lay down and lift their heads, you will see this classic midline bulging. This can be objectified in imaging as CT, MRI, or ultrasound. And there you can also distinguish between a rectus diastasis and a hernia, because it could also be an epigastric or infraumbilical hernia, but this can be distinguished on imaging. I told you before in the beginning that there are various classifications of diastasis rectus abdominis. I will just show you some. There's the Baer classification that uses the width of the linea alba at certain points, certain levels of it. The next classification is the Rath classification, also using the width of the linea alba, but at different levels, and it takes the age into concern as well. And then there's the Nahas classification, using the abdominal morphology. So they separated the rectus diastasis in 4 types. Type 1 would be a classic rectus diastasis, which you will find in patients with central obesity. Type B is a rectus diastasis combined with the infraumbilical laxity, often found after pregnancy. Type C is a congenital lateral insertion of the rectus abdominal muscles on the costal margins. And type D would be a rectus diastasis in combination with a poor waistline. So actually there's a problem with classification. And there was no common classification or recognized classification of diastasis rectus abdominis until 2019, when a working group of the German Hernia Society and the International Hernia Society set themselves the task to devise such a classification. And they considered a rectus diastasis abdominis to be a separation of the rectus muscles of more than 2 centimeters. So why is this relevant? Okay, the abdominal muscles are very important to maintain posture, and they are relevant in various movements of the body as well as in physical activities. So as in flexion, rotation of the trunk, and they stabilize the lumbar and pelvic spine. So when it comes to diastasis rectus abdominis, you will find the following symptoms. You will find patients with a poor posture and impact on trunk and pelvis stabilization. As well, they will be limited in physical activity, and they might report about limbopelvic and hip pain. But it remains unclear whether weakness and dysfunction of the pelvic floor, as well as incontinence or pelvic organ prolapse, is combined with diastasis rectus abdominis. So again here, what you'll see is many symptoms, many articles, but actually there's no conclusive data between symptoms and diastasis rectus abdominis. So now we talked a lot about problems. Are there solutions? And yes, there are. There are, on the one hand, conservative treatment options in exercise and physiotherapy. And what is recommended is, or like what people say you should do, is strengthen the transverse and rectus muscle. by posture training, Pilates, for example. But on the other hand, they say, don't do engagement of the oblique muscles too much, because if you engage your oblique muscles here, you might tear the rectus muscles even more apart from each other. So avoid abdominal sit-ups, lifting heavy weights, crunches, stuff like that. So now I want to ask you again, do you think that there's any kind of like evidence for conservative treatment in treatment of rectus diastasis?
I don't think that it exists.
Okay, thank you very much. In this review of 8 studies, including 340 women during the pre- and postnatal period, it was checked whether non-specific exercise might help to prevent or reduce diastasis rectus abdominis pre- or postnatal. And actually, there's insufficient evidence, so you're right. To recommend exercise as means of preventing or treating DRA. Let's come to the surgical treatment options. What are the indications for surgery here? First of all, we go for cosmetic discomfort as well as functional discomfort. So if the patient is suffering from pain or discomfort of the level of defect, we see it as an indication for surgery, as well as if the diastasis rectus abdominis is combined with a hernia, umbilical or epigastric. If so, it's mandatory to fix both problems at the same time. So let's sum it up again. Aesthetic and or functional discomfort or the presence of a hernia would be an indication for surgery. How do we do? Or what is recommended? What are the surgical treatment options? There's the possible of plication, where you just suture the rectus muscles back together. Or you can do plication and excisional techniques with a mesh. Both of them would be followed by abdominoplasty. The DRA is a very common topic. So, in the last couple of years, lots of repair techniques have been evolving. And they include endoscopic, laparoscopic, robotic, and hybrid techniques. And they have those names like ELAR, MILIS, E-MILIS, E-TABLERA, blah, blah, blah. We don't want to go further into that because we need evidence. So in this review from 2017, 20 articles were included, and they compared different repair techniques to each other. And what you see here is they compared open to laparoscopic plication, as well as modified reverse to stopper technique, as well as combined repair mechanisms. And what was found out is actually there's no valuable complication rates or recurrent rates available. So we can't say this technique is better than the other at the moment. Although the data situation is unclear, at least there are some advices for surgical treatment. As leave the myofascial continuity intact, align this muscle back in place. With the midline hernia, you can do plication excision techniques with mesh and reinforcement. And there are important endpoints, not only for us surgeons, but even more for the patient, which are cosmesis, pain, functional result, and recurrence rate. So what is our approach here at the USZ? We go for a DRI resection with preperitoneal onlay mesh and dermolipectomy, also known as abdominoplasty. And we do it together with the plastic surgeons. Now I want to show you some pictures of surgeries we performed. This one is a young lady, and she is suffering, and you can see that pretty clear here, from a midline bulging. In the CT scan, she had no concomitant hernia, but when we saw her in the outpatient clinic, she reported about really severe back pain. So what did we do? We did the normal suprasymphyseal approach. We prepared the subcutaneous fat tissue away from the rectus muscles. And I hope this video will work. Yes. And what you see here is that her linea alba was so thin that you can see bowel movement just beyond it. And here's the rectus muscle 1, rectus muscles 2, linea alba in between. So what we did afterwards is we prepared the dorsal rectus sheath away from the peritoneum and place the mesh in between. This is what you can see here. Rectus muscle, linea alba is cut away, and there is this mesh already in position. What happens next is we apply some fibrin glue for hemostasis reasons, and then next we would suture those both sheets back together. There's another example I want to show you. This is an older lady, and she's suffering from a laxity of the abdominal wall with concomitant infraumbilical hernia, which you can see here on the CT scan. So what did we do to her? Actually, basically, we first draw the midline and the incision line. Again, suprasymphyseary incision. Then we prepared, again, the subcutaneous fat tissue away from the anterior rectus sheath. And what you can see here is this large hernia already bulging out. Here you see it again, rectus muscle hernia. And this is what I told you before, the pathophysiology. Both rectus muscles are pushed to the side, gets longer and gets weakened. Next step would be cut away this hernia sac, replace the hernia. And then we will put also a mesh in between the dorsal rectus sheath and the peritoneum. Suture those rectus muscles back together. And what you can see here on the next picture is that if the hernia was gone and the rectus muscles have been put back in place, there is a huge excess of skin and subcutaneous fat tissue. So this is where the plastic surgeons come in, and they do the dermolipectomy here. And this is like after suturing the abdomen back together. And what you also can see here is that the umbilicus is lost at this part. So what is our patient selection about? All patients suffer from midline hernias, a rectus diastasis with discomfort clearly on functional or cosmetic level. They need to have a completed family planning as we insert a really huge mesh. And this can be like interfere with another pregnancy, so should be completed family planning, and they have to be ready to lose the umbilicus in the first place. It can be reconstructed afterwards, but first of all, they have to be ready that it's lost. And there are further important points we take care of. Actually, we have to visualize the midline, the diastasis rectus abdominis, and see whether there's a concomitant hernia with CT or MRI. We have to know the extent of the dermatolipochalasis. And what's also important is if there have been prior abdominal operations or scars, because if the patient maybe had a median laparotomy before, we would rather use this incision again to do another one, suprasymphyseary, to like really be careful with the vascularization to not harm it. So some before and after pictures. The young lady with the midline bulge. Now you see really nice flat abdomen, and what you see here is her posture already improved a lot. This is the other lady I showed you before with this concomitant infraumbilical hernia, and she has a really flat, nice waistline again. And this is just another picture I just want to show you because it's a beautiful result. Here we see this midline bulge of a rectus diastasis, and here's a really nice flat abdomen in the end. So where are we at the moment? We have limitation of actual data with very low scientific and methodological quality. There are at the moment many how I do studies with missing relevant endpoints, and there has been a missing classification of accepted classification of diastasis rectus abdominis. But there may be the first step, as the German Hernia Society and the International Endohernia Society brought off this classification of rectus diastasis as a separation of the rectus muscles more than 2 centimeters. And they proposed to include some more factors, which are very important, like the length of the diastasis rectus abdominis, if there are concomitant hernias, how many numbers of pregnancy the woman had before, what is the skin condition like, How's the diagnosis been made? Was there any previous operation or previous pain? So, there's the conclusion of today's talk. What we need is an accepted classification of DRA and well-designed studies to achieve valuable data to compare techniques. Multiparous women at highest risk for development of a DRA. A DRA is often a combined problem with myofascial laxity and/or umbilical or epigastrial hernias. The management options we have depend on the combined problems and on the patient's wishes. And the DRA should always be fixed in collaboration between visceral and plastic surgeons. I hope you could follow me easily through this lecture. Thank you very much for your attention. Now we're open for discussion and questions.
Yes, Janina, thank you very much for this excellent talk. I think you covered the topic well. Maybe 2 or 3 comments to this. First, in our clinic, we do not operate just if there is DRA. The DRA has to be combined with an umbilical hernia. And then we try to offer the patient a tailored approach. That means if we can offer the laparoscopic repair as also the open repair with a preperitoneal mesh, or if there is a large DRA with a large umbilical hernia, then we have this complex abdominal wall reconstruction that we do with the plastic surgeons. And I think it depends also on the patient's wishes, what we do. Then the second thing, when should we operate a woman? So I think we should offer this kind of abdominal wall reconstructions just when the family planning is completed, not before. Why? Because we do not know how these large meshes that we put in expand during pregnancy. There is no valuable data. And today we can say meshes up to 15 centimeters are okay. You can have a normal pregnancy, but if it's bigger, then there is no data available and there is some risk that the laxity is not here that is needed during pregnancy. And maybe the third comment on this definition of DRA, these 2 centimeters, I think it's too low, this distance of 2 centimeters. Samuel Kaiser, a former collaborator from here, published in Hernia last year that the prevalence in the Swiss population of DRA with this 2 centimeters would be 60%. So quite high number. And they measured in a CT scan in 350 patients the distance, and in our population, in the Swiss population, the distance would be normal, or is proposed normal to be 3 to 3.5 centimeters, 3 centimeters above the umbilicus. So I think these 2 centimeters will be challenged in the future still, and maybe we will get another classification of DRA in the next years. Yes.
Okay, thank you very much.